All right, hello, I'm Gavin Siegel. I'm one of the new colorectal surgeons here at AdventHealth. It's nice to meet you all virtually. Hope to get a chance to meet you all in person when we deem it safe. I just got here to Tampa, where I left Denver, Colorado. I was in private practice in Denver, Colorado. I was there for about 5 years, and prior to that, I was in Washington, D.C., working at Georgetown and Washington Hospital Center, where I was actually partners with Dr. Chudzinski, so that's the connection that brought me here to Tampa. Today we're going to talk about some updates in hemorrhoid surgery, and I'll try and spare you from some of the monotony that has to do with hemorrhoids and kind of focus on the surgical aspect of it. So I'm going to go ahead and get started here. So again, I don't want to spend too much time talking about physiology, but we'll cover that just kind of briefly. I'd like to focus mostly on the surgical treatment options and hopefully cover some information that's new to you all and helpful to you all. So specifically within treatment options, we'll kind of go briefly over some non-surgical options. Not going to spend a whole lot of time on that either, but we'll at least touch on that and spend most of our time on the surgical options. Specifically, we'll talk about surgery for external hemorrhoids. We'll talk about the kind of gold standard in the hemorrhoid surgery world, which is excisional hemorrhoidectomy. Then we'll cover some new, maybe some new ideas for you and some newer treatment options. We'll talk about THD, stapled hemorrhoidectomy, and then laser hemorrhoidoplasty. So we'll just briefly talk about hemorrhoid physiology. See from this picture that when the hemorrhoid cushions are under low pressure, they're able to engorge and add appropriately to the continence mechanism. And this is sort of an example of when we sleep. That's why we don't leak stool when we sleep, is because we do have some internal sphincter tone and some assistance from the hemorrhoidal piles there. However, kind of in the lower picture, when we do have some pressure, as with some of the anal rectal pathologies, the cushions shrink and tend to contribute a little bit less. So there's a number of theories that have been proposed, and there's really been not a whole lot of advancement into our understanding of why hemorrhoids actually cause problems and become symptomatic. Some of the theories we can go through. So with time, the anatomic structures that support the muscular submucosa weaken, and this allows the cushions to slip or prolapse, which can lead to hemorrhoidal symptoms of prolapse, bleeding, pain, itching. There's pretty good evidence that the supporting tissues can be shown to have microscopic deterioration by the third decade of life. And once these tissues do prolapse, then the internal sphincter muscle increases tone and kind of slows the rate of venous return and increase our hemorrhoidal engorgement, which can lead to further symptoms. Then lastly, the increased vascular supply and neovascularization can play a role with some patients that have hemorrhoidal symptoms, as the superior hemorrhoidal arteries have been shown in these folks to have a larger diameter, greater flow, and even higher peak velocities. So there's really no one simple explanation, and it's likely a combination of several of these factors, which sometimes makes it a little challenging to explain to patients. But you know, when we kind of talk about all these things together, it makes it a little easier to understand. So let's go through some treatment options. Hemorrhoids have long been a problem, and it's difficult to estimate really what the actual incidence is in the U.S. The best numbers that I could really find were about 5% of the population suffer from hemorrhoids, with over about 300,000 hospitalization admissions each year and about 2 million prescriptions written. So the most common associated with problems is most common associated problem with hemorrhoids is constipation. And so many of the surgical treatment options really focus on improving this. And specifically with this, we talk about fiber therapy. So a diet high in fiber is really the most common treatment option, along with increased water. And I think we probably all know the numbers. Men are trying to get 38 grams of fiber a day. Women, the goal is 25. And in the United States in general, the average person gets about 16 grams of fiber. So not enough fiber in our diet. And this hasn't really changed over the last 10 years. I know in my practice, I'm a real strong proponent of fiber for just about everybody. I do understand it doesn't work for everybody, but just about everybody that comes into the office gets a recommendation to increase both the fiber in their diet as well as some sort of other kind of fiber, psyllium fiber, something like that. So is this effective? Well, studies have shown it's actually really effective for bleeding, but it doesn't really help with pain, prolapse, or itching. And so there's some other options out there, topical options. We can look at, there's really $1 billion industry, a lot of the over-the-counter agents. There's not a lot of science to support many of these. One of the most commonly mentioned is calcium channel blockers, that there is some evidence for thrombosed external hemorrhoids that it helps with pain. But most of these, I'm sure as you all have heard as well, there are some patients that really do well with these and most patients do not. And there's just not a lot of science about it. So then we move on to some more sort of aggressive non-surgical treatments, and I'll just kind of touch on these real quick. I know this is a topic that you all are very well versed on, and so we'll just kind of get some highlights here. So RBL, which is rubber band ligation, this is the most effective and most common office-based non-surgical treatment. It's relatively easy to do in the office. It's relatively pain-free. What I typically tell my patients is that give them kind of a fair warning that, again, this is easy to do. We can do it in the office, but most of the time they're going to need to have this done more than once. I found if you kind of temper their expectations and tell them this is going to need to be done a few times, a lot of people will be okay with that. However, folks that are coming in looking for a quicker, more effective solution oftentimes aren't happy with this and or may go somewhere else. A little less effective, but still kind of on the same spectrum of ease of use and able to do in the office is infrared photocoagulation. Again, not quite as effective. A little bit more than 30% require additional procedures. But again, there's not a huge downside to it other than the folks that want something done a little more quickly. And then lastly, we'll talk about sclerotherapy, which is along the same lines as infrared photocoagulation when you're talking about doing it when you're talking about 30% requiring additional procedures. But kind of notable about sclerotherapy is that it's useful for anticoagulated patients. So that's an option in those situations. So the bulk of what I want to talk about today really is surgical options. We'll just kind of touch real quickly on thrombosed hemorrhoids. So as you all know, this is really the acute onset of anal pain with a hard lump in the anal area. Most patients are able to feel this. Most patients know they have it. It's not really a subtle thing. Most of the literature, and you all have seen this as well as I've seen this, after about 4 days, it leads to pressure necrosis. You end up with skin ulceration, some spontaneous evacuation of the clot. This usually makes folks feel better once they have the clot evacuated, but it does depend on the amount of pressure necrosis and the amount of skin ulceration. So some folks come in actually feeling a little bit worse once they've gotten to this point. So management from a surgical standpoint usually is guided by the patient's level of pain. So if we catch them in the first 3 to 4 days and their pain is kind of on the rise, what we'll typically do is an operative thrombectomy in the office. So just put them in the lateral position, inject some local anesthetic, and then we do an incision over the thrombosed hemorrhoid and take out the actual thrombus. Folks get quite a bit of relief from this. The downside of it, and I do kind of warn patients, is it does leave you with an open wound. We found that closing these kind of leads to infection. So typically we leave them with an open wound, which is usually about 1 to 2 centimeters. Does require some gauze to be placed in the cleft, usually for about 2 to 3 weeks. And so we just talk with folks and make sure that they're aware of that. If they come in to see me and they're kind of after the most painful portion of this, so if they're after day 3 or 4, I'll usually talk with them about allowing this to resolve on its own without surgical measures. Talk about making the bowel movement soft by adding some kind of fiber, increasing their water intake. And again, these are patients that don't have any signs of pressure necrosis or don't have any skin ulceration. They just kind of have a lump there that is getting softer, doesn't have as much pain, and is actually starting to improve. I will give them the caveat that it's going to take them 4 to 6 weeks for it to be completely gone. And if some folks aren't happy with that and they want to have the the clot removed before that 3 or 4 weeks, then we'll go ahead and do that in the office under local again. As we kind of mentioned before, a lot of times we'll give them topical calcium channel blockers, and this just helps with symptoms of pain, especially folks that are on the downward side of the pain spectrum or the pain graph. And this is just a quick picture that gives a idea of kind of how we do this. So again, just inject with some local anesthetic, and then you're able to open up the hemorrhoid and take out the clot. And we usually leave a little elliptical incision there. Again, it's about 1 to 2 centimeters, and we leave that open, let it heal over the course of about 4 weeks. All right, so let's move on to some surgical options for internal hemorrhoids or combined internal and external. The best operation, should be effective, should be well tolerated, should be safe, and should be reasonably expensive. We don't want to make the treatment worse than the disease. Again, we want it to have low rates of recurrence, high rates of efficacy, and we want it safe, making sure that the treatment adequately treats the disease without putting patients in harm. And as far as reasonably expensive, this is something that really holds true for our healthcare system across the country. I think we've all encountered that. So this is a picture of what a excisional hemorrhoidectomy looks like after surgery. You can compare this to the previous picture. Basically, you're going to excise all 3 of the piles, both internal and external. You suture up the internal portion of it, and then leave the external portion, roughly 1 centimeter open so that it can drain, doesn't get infected. This is really the gold standard, the open excisional hemorrhoidectomy. It's very effective. You're looking at recurrence rates less than 10%, usually in about the single digits. It's reasonably inexpensive. You can do this, with a bovie and some anesthesia. There's not a whole lot else that's needed. Some suture. The problem comes with the fact that it's not without complications. We do have a fair number of complications associated with this, and patients hate it. So this is by far the #1 phone call that I get in my office after folks have had hemorrhoid surgery, because it's just not well tolerated. They have really significant pain for 4 to 6 weeks. I tell them they're going to be miserable for about 6 weeks, not to make any plans because they're not going to feel well enough to do anything. And we've tried a number of different things, number of long-acting injectables. We've tried different pain medications, and we really haven't been able to find a good answer to how to make this procedure better tolerated. So what are some of the complications? Well, most common one that we see is urinary retention. This is very common, especially in older men. We don't really have a great idea why this happens. We think it has something to do with the prosthetic plexus, but it's also a combination with the anesthesia that paralyzes the bladder. And this is actually a real problem. I don't have numbers for how many open hemorrhoidectomies have trouble with urinary retention, but I would say that's probably around 30–40%. And the problem with this is it's going to require Foley insertion, and it's typically after they've woken up from their hemorrhoid surgery, so they're already miserable from having their hemorrhoid surgery, and now you got to put a Foley in them and send them home with it. So not a fun situation and pretty common. We've learned probably in about the last 10 years that we can avoid this by restricting their fluids during the time of surgery. So we keep the bladder non-distended. Again, we're not entirely sure how that helps, but we do keep the fluids under about ½ liter for the case. And then with increased pain control. So again, we've tried some other long-acting injectables like Exparel. We use more NSAIDs. So moving on to some other complications, post-operative hemorrhage. This is relatively rare. I think that we've gotten better at doing hemorrhoid surgery and kind of learned from our mistakes over the past 50–60 years how to avoid hemorrhage. And again, it is pretty rare, but when it happens, it usually requires another trip back to the operating room to find out what's bleeding and to put a suture into something, pack the rectum with gel foam, however we can get it to stop, but it does usually involve another trip back to the operating room. So it becomes pretty uncomfortable for the patient. They just had surgery, now they're going back to the operating room to have more surgery, so it becomes a little bit of a problem. Anal stenosis. So this is a complicated issue. Do see a lot of this in our practice. from hemorrhoidectomies that were done 30, 40 years ago. It's becoming more rare because we've learned, again, over the last 50 years to stop doing a particular kind of hemorrhoidectomy called a whitehead hemorrhoidectomy. But we still see this from patients that have had this done quite a while ago. And the big issue with this is it's hard to treat. It's really hard to manage. Usually involves some kind of flap repair, rotating some sort of flap from the anorectal derm into the internal area. And again, this is a really difficult problem to treat when it does happen. Post-op infection, again, pretty rare with hemorrhoidectomy, but this can be life-threatening. You can end up with pelvic sepsis. I have seen this several times, all the way to the situation where it involves a trip to the operating room and diversion with a colostomy. So nobody really expects that to be the situation they're going in for when they elect for hemorrhoid surgery, but this can happen, and it does happen with open hemorrhoidectomies almost specifically. Lastly, we're starting to see more and more of this, starting to see more fecal incontinence. And this is because we've been doing hemorrhoidectomies now for 50, 60 years, and those folks have gotten older, and the damage that they had done with their hemorrhoidectomy when they were younger is now starting to show up as the muscles thin and impairs the incontinence mechanism even more now that there are no hemorrhoids and the muscles have started to thin. And again, this is probably higher than we suspect because we haven't been following patients long enough to find out if they become incontinent in the later decades, 60s and 70s. But we're starting to see more of it and starting to realize that this is a bigger problem that can be associated with anorectal surgery. This is a little bit of a busy graph, but kind of the things to focus on here are, this is incontinence rates, and this is actually a British study. But in females, it's largely due to obstetric injuries or obstetric lesions. You can see there it's 82%. However, in men, incontinence increases or gets more common with anal surgery. There you can see up to 59%. So again, we're starting to realize that this is causing problems long-term downstream as folks get older, and it's becoming a bigger issue that we're seeing a little bit more often. So we kind of figured out that open hemorrhoidectomy has some complications that aren't so great, and so we've tried to come up with some other alterations to it to see if we can make this a little bit easier to tolerate. Still the same operation, and the principle is the same, but we've tried using different sources of energy. Specifically, we've tried the harmonic scalpel. So the harmonic scalpel is an energy-based mechanism that uses ultrasonic vibration to remove the hemorrhoids. Some other methods we've tried, the ligature, the thunderbeat, the end-seal, these are all, various methods that are based on bipolar cautery and adding pressure to them. So what do we find? Well, it wasn't that much better. You get slightly lower pain scores in the early post-op phase, but it's really the same at 14 days. There wasn't really any change in any of the other post-op complications. Sorry, that's supposed to be complications. And it's considerably more expensive. So I think this really has gone out of favor. I know when I was in my training 10, 15 years ago, there were a lot of folks doing this, and probably still a lot of folks doing it because it does decrease the pain, in the first 14 days, but it really long-term doesn't help anything, and you still have the same complications that you do with open hemorrhoidectomy. So are we kind of left with a situation where it's no pain, no gain? Don't really have any good options. If you have hemorrhoids, you go in, you got to get them cut out, and that's kind of it. Not really. We've come up with some other surgical options, probably in the last 20 to 30 years, that give some better pain control with some similar outcomes. We'll talk first about the stapled hemorrhoidopexy. This was first described in 1993. Wasn't really popularized until around the early to mid 2000s. What this does is it removes a circumferential ring of mucosa and submucosa above the dentate line. It results in less post-op pain and a quicker return to normal activity. It's not difficult to learn, it's not difficult to teach, but if it's done incorrectly, it can have some unique consequences, and this has really come to light in about the last 10 years. In addition, I used to do quite a few of these in my practice when I was in DC. And one of the issues that I came across is folks are no longer able to insert anything into the anal canal because there's a row of staples. You can imagine what kind of folks this would pose a problem for, but it's also with a lot of things as simple as putting suppositories in. But this did happen to be an issue with some patients that they didn't really like. So this is just kind of a picture of how we do it. You can see the stapler there has a anvil at the top, and you put suture circumferentially around the anal rectal mucosa. You pull it into the anvil and then staple it down after it's been married to the stapler, and it creates a row of staples circumferentially and removes the hemorrhoid tissue. So sounds like a pretty good option, right? Well, we've kind of learned after doing these for the last 20, 30 years that there are some difficult and serious complications that we'll kind of go through here. It is a good operation, but when done correctly, sometimes you can still have some of these issues, and I have seen quite a few of these in practice. And again, they're very difficult to deal with. So you can end up with some full thickness rectal perforations. I've seen a lot of folks that have persistent rectal pain up to a year afterwards with no real explanation. Seen several instances of retroperitoneal sepsis, and again, this can be relatively serious enough to take you in for diversion or post-anal space drainage with catheters. Seen quite a few instances where that staple line gets a little bit ischemic, and it'll form a little stricture there, so you end up with some rectal obstruction or stenosis. And a couple times seen rectovaginal fistulas because you get some of the tissue from the vagina incorporated into that staple line, and then you get a little bit of ischemia with that, and it turns into a fistula. Overall, it has a slightly higher rate of recurrence than hemorrhoidectomy, which is, again, our gold standard. It's kind of limited to doing grade 2 or 3 internal hemorrhoids. You can't really use this for 4, and it doesn't work for minor or mild symptoms. So again, what we've learned after doing this for the last 20 to 30 years is there are some unique complications. It is tolerated well. We do have a better pain scale with this than we do open hemorrhoidectomy. It is economically viable, but sort of in the colorectal surgery community, we've kind of learned, again, that there are some questions about this. So I think it's kind of been out of favor recently in the last 10 years or so. So we kind of went back to the drawing board again, looking for a more ideal operation. We came up with transanal hemorrhoidal dearterialization. This was first described in '95 and has really gained some traction, I would say, in the last 10 years as we start looking for better options for hemorrhoids. What this is Doppler-guided localization and ligation in the terminal branches of the hemorrhoidal arteries. And then you can add a suture rectopexy of the redundant or prolapsed hemorrhoidal tissue. So this is a picture. You can see the Doppler probe there in the anoscope with the suture driver and the needle inside of it. And there's a little window there where you're allowed to place the suture around the hemorrhoidal artery. So what you do is you find the hemorrhoidal artery with the ultrasound, and then the vessel is ligated with the suture. The idea behind this is ligation of the feeding vessel to the hemorrhoid will shrink the size of the hemorrhoid. And again, this is done above the dentate line, so there's really minimal pain with this because there's no pain fibers that go to the area. We do this in 6 locations. We do it at 1, 3, 5, 7, 9, and 11, sort of in a clock with the patient sitting in lithotomy, so that we ligate all 6 of the branches of the hemorrhoidal artery that feed the hemorrhoids. And you can go back and confirm with the Doppler after you've done this to make sure that you adequately ligated it in all 6 of those spots. And here's an example of after the stitch is placed. You put a little figure of 8 stitch into the hemorrhoidal artery under Doppler guidance. You tie that suture down and then go back and check it with the Doppler to make sure that you got it. And do it again, six different spots around the anus. So in addition to the artery ligation, you can add a rectopexy, which can be added to the suture that you placed for the hemorrhoid artery ligation above. Do this above the dentate line, so really the pain profile is pretty low. And what this does is actually pull the prolapsed tissue back up into the canal and causes it to scar down against the wall and ablate the hemorrhoid by a combination of, again, scar tissue and ligating the hemorrhoidal artery. So we can see it there in the pictures. And same as the hemorrhoidal artery ligation, we do this in 6 spots all the way around the anus, and then confirm with the Doppler that you got the hemorrhoidal artery. So again, like we mentioned, it's all done above the dentate line. So pretty good pain control profile. Most of these folks have pain for about 7 to 10 days, and it's more of a pressure than a pain because you're really doing the mucopexy all the way around, and it really tightens up the rectum in the proximal anus, so they mostly get a pressure as opposed to pain. Has a really good recurrence rate profile, so about 10% prolapse, 10% recurrence of bleeding, and 10% pain with having bowel movements at a year. So pretty close to our gold standard hemorrhoidectomy. Not quite as good, but pretty close. So the one drawback with this really is that we need more studies on this procedure. And we're working on doing that across the nation. We had a multi-center study that's been going on for about the last 3 years that has been put on hold this year, mostly due to COVID. But hopefully we can get that ramped up again with a bunch of the other hospitals around the country. And again, it does appear to be effective, reasonably inexpensive, safe, and most patients tolerate this really well. I haven't seen a lot of major complications from this. We do end up with a little bit of urinary retention. I'd say it's considerably less than doing open hemorrhoid surgery, open hemorrhoidectomies. And outside of that, I haven't seen any bleeding because you're really not making any incisions. It is also safe to do with folks that are on anticoagulation medications that come in with grade 4 hemorrhoids into the emergency room and need something done right away. So it's really useful for that. And you can use this for all different types of hemorrhoids. So it's really easy to do with all grades 1 to 4. Occasionally, I'll have to do it more than once in a patient that has grade 3 plus to 4. But I've done probably about 700 of these, and I've had to go back and do it again maybe a dozen times. And most of those folks you can kind of predict and tell them, hey, we may need to do this again in about another 3 to 4 months just to kind of get this all under control because yours are a little more severe than most. All right, the last option I want to talk about is kind of more of a future direction. This is something that I learned about last summer. It's a new procedure. They've been doing it mostly in Germany for about the last 2 to 3 years. It's called laser hemorrhoidoplasty. Again, there's no data really in the United States, with not a whole lot of folks doing it. I think, you probably find a dozen people in the United States that are kind of dabbling in this. And so far, what we've determined is that it's useful for grade 3 and grade 4 prolapsing hemorrhoids. Not probably a little bit overkill for grades 1 and 2. Doesn't work so well for there, and you'll understand. I'll show you a video of it here, and that'll kind of help you understand why it's mostly just used for grade 3 and 4. Overall, with the experience in Europe, this has been touted as having less pain and less morbidity, and tends to shrink the hemorrhoids. It's the kind of thing that they've been able to do 2 or 3 times on folks, so they shrink them down a little bit every time and have to do it 2 or 3 times, but there's really not a whole lot of pain, so patients tolerate this pretty well. And here is the video we'll watch. So these are examples of prolapsing internal hemorrhoids. So these folks are taken to the operating room, given a general anesthetic. You put the anoscope in so that you get the hemorrhoid to prolapse, pull it kind of out of the anus so that you can get a better view of it and manipulate it. You then make a little incision in it, which they don't show, but you make a little incision into the hemorrhoid, and then you pass the laser catheter all the way into the hemorrhoid under the anoderm, and then slowly withdraw the laser catheter as you come out. And it basically just uses cautery to burn the inside of the hemorrhoid and get it to shrink down. So I don't think this is really caught on yet in the U.S., but there are some folks that are doing it. I've seen it done in the operating room. Haven't done it myself yet, but it's at least just something that is on the horizon. All right, that's what I got. Any questions?
What is the most effective way to deal with the skin tags, which are annoying?
Yeah, see a lot of that, especially after folks have had thrombosed hemorrhoids or several thrombosed hemorrhoids. There's not a great way to do it. What we typically do is take them to the operating room and snip them off and then try and sew it up. The result isn't great because the skin there is so stretchy and you're always using it. So I just give them a caveat and say, hey, we can snip these off in the operating room, but it's probably not ever going to look like it did when you were 19.
I have a question from Dr. Friedland. He's just having some the muting and video issues. He says, since all above dentate line, are external hemorrhoids positively affected?
Yeah, great question. So the THC doesn't work great for the external hemorrhoids, but it does pull them inside some. So you will get some results with that. And again, when I talk with the patients about that, I kind of give them a caveat and say, this really treats the internals much better than it does the externals, but you will get some benefit with the externals. So if they have minor external disease and the majority of it's internal, then I'll go ahead and do the THD and tell them they'll get some results with it.
Is there any relationship between the hemorrhoids and anal fissure?
Not really. Anal fissures, from what we can tell, is typically caused by increased sphincter tone. There have been some studies that show, specifically in men, worse hemorrhoids with increased sphincter tone and fissures. So in that sense, there's a relationship, but I think they're really two separate entities.
Hey, have you treated rectal varices surgically?
Yes, we do our best to stay away from those, as you guys know, but when you have someone that's bleeding pretty extensively from rectal varices, the best way to treat those is with some kind of ligation or some kind of suture procedure. I'm trying to think, I've probably run into that maybe a dozen times where you have patients that are really bleeding extensively from those, and it's hard to deal with because a lot of times it's hard to find, and a lot of times even when you keep putting sutures in, then they keep bleeding. So the best way is to treat the liver disease with a TIPS, but in the sort of emergent circumstance, you're really kind of limited to just throwing sutures in those.
The same principles of treatment apply to treating the hemorrhoids even if patients have Crohn's disease?
No, good question. We tend to avoid doing open hemorrhoidectomies because they won't heal those incisions because of the inflammation that they have with the Crohn's disease. So the THD procedure is actually a good one for Crohn's patients because there's no incisions, and so there's really nothing for them to heal. So that's definitely my preferred method for patients with Crohn's disease or ulcerative colitis.
Hey, Dr. Sanjeevi here. Question regarding women who have, like, say, pelvic dyssynergia, pelvic outlet obstruction, rectocele and such. What are the recurrence rates, and are there any unique complications you have to anticipate with hemorrhoidal procedures? Yeah,
the biggest issue with that, especially with a rectocele, is you don't want to get into the rectum. You don't want to put sutures. I'm sorry, you don't want to get into the vagina. So you don't want to put sutures into the vagina. You don't want to staple into it. You don't want to, cut out a piece of it when you're doing an open hemorrhoidectomy. So there's no real good way to do that other than just making sure that you're aware of where the vaginal wall is at all times. And when we do these cases, especially the way we teach our fellows and the way I was taught, is before you do anything that's you can't really reverse, you want to put a finger in the bottom of the vagina and make sure you know where you are with regard to your sutures, with regard to your staples, with regard to your incisions. So you're always really checking the vaginal side of it to avoid injuries with that. I would say most of the rectovaginal fistulas I have seen are a result of the stapled hemorrhoidectomy. I'm sorry, most of them I've seen that are sort of not predicted or wasn't done because the procedure was done incorrectly. It was just done because they accidentally grab a piece of the vagina when they put that suture in, and that's almost always done with the stapled hemorrhoidopexy.
This is Mohammed Kaif. I have a question about, do you have any information about the effectiveness of endoscopic band ligation?
As far as I can tell from reading the literature, it's really the same as doing it in the office. I do both, and I think I get sometimes a better visualization of where the dentate line is, because you can, retroflex the scope and you can see the dentate line a little bit better than when you have a patient just lying on their side putting a scope in them. It's a lot of times more convenient to do it that way if you're doing it with a colonoscopy, so that's always an advantage. But from an effectiveness standpoint, I'm not aware of any difference.
And when you do it, do you limit to one or two and then go back?
Yeah.
The same principle.
Yeah, you got it. I won't do more than two, whether I'm doing it endoscopically or whether I'm doing it, with an anoscope.
Well, thank you all for joining us this evening, and thank you, Dr. Siegel, for presenting.
Yeah, thank you. Thanks for having me, and I look forward to meeting you all in person.